Look, I'm Vanessa Harris, as Marie said. I'm an Aboriginal woman, and my family are from the Northern Territory, and my grandmother was part of the Stolen Gens. So our family group is the Aliwara language group that we're from, which is from a community in the Northern Territory called Elparula. Look, I've taken on the job as Executive Officer of the Northern Territory Mental Health Coalition, but I also bring another perspective, which is my lived experience of being an Aboriginal woman and working mainly in Aboriginal health for many, many years. So this is a new role for me, working in a mainstream peak body representing community mental health organisations in the Northern Territory. So I suppose that's the perspective I come to this conference, and also the view I have around from an Aboriginal woman's perspective of what this looks like for us in the NT.
And it'd be great to talk a little bit more about how that's informed your thinking around the NDIS, but can we talk first about how is the NDIS rolling out in the Northern Territory now on mental health? Look,
they had a trial site in the Barkly, and that was sort of one of the trial sites like the Barwon site here in New South Wales. And the trial site raised a lot of issues in the Barkly, and certainly I know the NDIS and the NDIA are working through those issues. There was a rollout also in Darwin and Alice Springs in July of this year, of 2018, but certainly in 2017 of January it rolled out in East Arnhem. And I think the parallels with that was that in East Arnhem there's an Aboriginal medical service called Meewatch Aboriginal Health Service, and I think they were very much on the front foot with the NDIS and what it was going to look like for their clients out there, because they take up quite a big regional sort of service delivery hub the community control sector does. And I think the model of that, of incorporating the NDIS with inside an existing, the Aboriginal community control look at themselves as providing comprehensive primary health care. So they were very, I think, astute in, if they were going to do the NDIS, they wanted it to be incorporated into that model of comprehensive primary health care. And I think some of the lessons learnt from some of that is that they were very much on the front foot about the clients. They are our clients, the Aboriginal clients. They are already getting a service from us through some comorbidities. They're getting primary health care from the community control. So this was just another add-on as such. And I'm not suggesting that they didn't have to change their business model and they didn't have to re-look at and think at this, but I think that model was an interesting model of how the NDIS has been incorporated in East Arnhem.
What about beyond that? And you did refer to one of literature's greatest products, the Emperor with his clothes.
Yeah, look, that's my sort of personal opinion. I feel that watching the NDIS roll out, watching the anxiety around the NDIS, watching how people on the ground and the people who are affected by the NDIS, and some of the issues that we've been raising nationally as well around the issues, and we've written quite a lot through our peak body, which is Community Mental Health Australia. It feels like, the Emperor that goes down the street on his lovely white horse, and everybody sees the golden coat. And for us, we can't see the golden coat. All we see is the naked Emperor on the horse. And I think this conference has raised a lot of those issues around the system still needs a lot of work, and there also needs to be a health system that works in a model that supports all of this. I think, look, the NDIS, and if people get an NDIS package, I think it's a wonderful, wonderful thing. Don't get me wrong. But I think if you've got a package and you live in a really remote area, you've got this type of ticket. It's like a Willy Wonka ticket. And it might have $100,000 for you a year because you've got comorbidities or because your diagnosis needs this support. And I'm not suggesting you don't. But where do you go in a remote community to purchase? That's the whole thing. It's a purchasing power. And if you can't purchase, because if you talk to people who are delivering services out there, it's not cost effective. So
You talked yesterday about what service will go to a place where there are 5 people to serve, but you also talked about just a different structural things, like in Catherine you said there's no GP who bulk bills. So one, people can't afford to go, but that then informs whether or not they have a paper trail with which to prove eligibility.
That's right.
Well, how much are those sorts of problems, impacting on people's lives up there now?
Well, I think, look, the federal government talks about if you're feeling unwell or you're feeling depressed or, you go to your GP. Your GP is your one-stop front door shop. The problem we're facing, I think, not only in the Northern Territory but Australia-wide, is that the GPs are feeling a little bit overwhelmed with all this. They've been asked to fill out a whole lot of documentation by the NDIS before people can even be eligible. So if you go to a GP and you don't have a GP that bulk bills, who then also has a history of you, and it could be a GP that's only been there for a short time, there's barriers to that. So if you can't access a GP because of lack of funding, or when you do access the GP, your history of being unwell is not there. So they're all sort of barriers to not accessing, 3 years, what we've been hearing is 3 years of history that then lines you up to see whether or not you're going to be eligible for an NDIS package. And this is in mental health. I think you'd fare, I'm not suggesting you'd fare better, but I think having a comorbidity that clearly says, look, this person's been unwell for many years, they've got this other disability, and yes, okay, they've also got a mental health problem. I think that fares, because people can touch it, they can put a Band-Aid on it, they can understand that disability. So I think they're barriers, that's what I'm suggesting. They're just barriers to people accessing an NDIS package.
So have you heard anything here that you feel could lead to solutions, especially for remote areas?
Yeah, look, I think for remote areas, a lot of them don't have their own GP, so they're FIFO by the hospital system, which is the NT Health Department. So doctors fly in, or the mental health team fly in, they do their assessment and they fly out. So even though they might be based in a region, like for instance Nullarbor, there's a mental health team there, they're not on the ground long enough, they don't get to know the clients very well because they're not there long enough, and also there's high staff turnover in the Northern Territory anyway. So I think some of the solutions are, and we've been advocating for a while, is that it has to be incorporated in an existing model of primary health care, really. It has to be NDIS, or mental health has to be incorporated in that. I think standing alone doesn't support people through their journey. And I think going on what Scott Avery said yesterday from the Indigenous National Disability Service is that it's that idea of inclusion rather than this self-centred care. And I think in a remote community, people don't see themselves as an individual that has a package and then there's no other supports around them. They're going to still have their supports. They're still going to have their family. They're still going to have the wider community support. But they're not recognised in an NDIS package. So I think that has to be incorporated into a much broader health system to support an individual.
And we've heard a lot here from politicians and from the NDIA representatives that they're here listening. Do you feel that you have a way to feed that feedback back to the system and to try and bring around change that actually will work for people with mental health issues in the Northern Territory?
Look, I think there's been a lot of lobbying by certainly Mental Health Australia, certainly we're members of Mental Health Australia and also Community Mental Health Australia. I'm not sure if they really get what's happening in the Northern Territory remotely wise. I think they are hearing from really, there's some peak bodies in the NT, and I'm not sure if they're talking to them, which is AMSAN, the Aboriginal Medical Alliance NT. I'm not familiar or know if there's been conversations with NACHO, which is the national, and I know those are two organisations that haven't come out and said, look, this is the NDIS, this is what we're doing or what not we're doing. And I think they're the bodies that they should be listening to, especially in the NT. I'm the peak body for mental health, and I very rarely get a visit or a phone call. I'm not funded by the federal government, so we're a little bit invisible, I feel, as a peak body. But my members are 35 members, and they're not only working in Darwin and Alice Springs and Katherine and Tennant Creek, they are also in remote communities working. So they're already delivering services into remote communities. So I think not listening or not really sitting down with us and having a conversation, and with those other peak bodies, I think they are missing their mark slightly as well.
Thank you very much.